The next topic we are going to talk about is, I think, going to be a little bit more polarizing from what I know about my two faculty members. We are going to have a discussion as to which central line we should be doing. Should we be doing ultrasound-guided IJs or subclavian lines? And the first lecture that's going to go is by Dr. Saigan, one of my good friends. He's also the assistant residency director at New York Presbyterian Brooklyn Methodist Hospital, and he's going to talk about more of a pro-subclavian central line approach. Take it over.
Thank you, Dr. Adamakos. And I'm super stoked and absolutely humbled to be part of this panel of great speakers. So I was tasked with, or kind of volunteered, to discuss the subclavian side of this central line controversy. And as I was preparing this talk, the number 3 just seemed to keep coming up. And I don't know if it was my infatuation with number 33, or if it just truly presented itself that many times, but I can't help but discuss my topic in sets of 3s. So first, I'm gonna give you some 3 disclaimers, followed by 3 questions that will hopefully shed some light on this subclavian topic. And then I'll give you 3 tips so you can hit that target, which is that juicy subclavian vein. So to start with disclaimers, I want to get right to it. The first disclaimer is, unfortunately, I am not a dinosaur just yet. I graduated residency from Staten Island Hospital in 2015. And I say this because subclavian line wasn't the only line at my disposal. In fact, ultrasound-guided IJ probably was. But I was fortunate enough to have seasoned attendings teach me this and pass on this gift so I can be confident enough to practice and teach it. Disclaimer number 2, I am no cowboy, despite my miserable attempt to look like one the one time I went to Montana. With those jeans and the boots, yeesh. But in all seriousness, I'm not this tough guy ER doc who needs to plead subclavians in every single patient. I think I practice careful evidence-based medicine. Disclaimer number 3, I don't hate ultrasound. In fact, I love it. Before being introduced to this fleet of ultrasound machines at my current shop, which is a robust ultrasound department, I was trained in it to become a regular part of my practice. So now that the disclaimers are out of the way, let's get to our questions. First question, what makes the subclavian better out of these 3 choices? And in particular, what makes it better than the internal jugular? One thing I can tell you, it's been around for a while. I'm gonna take you to France once or thrice over the next few minutes. But there was a French paper that in 1952 that first introduced the subclavian line, as opposed to the internal jugular, which was proposed in late 1950s, early 60s. But just because it was introduced first doesn't mean it should retain its first position. So why is it better? You know, given that the location of the line doesn't really change its function, we have to look at the long-term and short-term effects that it has on our patients. In particular, the long-term effects of central line catheterizations are infections and thrombosis. So first take a look at our trauma patients. And this paper looked at which lines had more infections in severe trauma patients. And it's an important subset of population because this is a situation where our hands may be tied, where subclavian is our primary location. So what did they find? Infection was significantly less in subclavian lines, and even so much so that they recommended rapid switch to subclavian lines if an IJ or femoral was placed initially. So that's our trauma patients. And I'd be remiss to be speaking about infection in 2020 without bringing up the 3 letters of the CDC. And they actually have their recommendations as well. And of course, it was their 3rd bullet point that they recommend subclavian site over the other 2 to minimize infection risk for non-toned CVC placement. So if that's not enough for you, let's go back to France. 63 years later, after their initial paper in 2015, a group in France, of course called the 3-site study group, published this paper in the New England Journal of Medicine, and it looked at the intravascular complications of all 3 sites. So what did it find? And I want you to focus on the orange and red as I conveniently shade out the first part. Of the 3 choices, when they had the choice of the 3, you can see that infection again was significantly less in subclavian, and as well as thrombosis. So that kind of tallies up our long-term risks of these lines. But the one that's mostly considered is the short-term risk of sticking a needle in the patient's chest. So is it safe? Okay. And then we'll go back to France for the 3rd time. And while the primary goal is to compare the 3 choices of this study, they actually did a head-to-head analysis when one of the lines wasn't available. And I know this is a busy slide, so don't strain yourself, but I want you to focus on this number here, and I'll blow it up for you. When subclavian was compared with jugular, it had more pneumothoraces, sure, but the major mechanical complications was also included bleeding and hematoma. There was no significant difference, which means subclavian was not inferior to jugular when it came to safety. So it was just as safe. Which brings me to my third question. Should we be teaching it? Should we be learning it? Should we be practicing it? It's three questions in itself, but should we be teaching it? And that answer is an absolute yes. We are the jack of all trades in the house of medicine, and we are expected to do procedures in all types of patients. When I go on vacation, I don't be limited to the places that I want to go. And just like when I want to put a central line, I should not be limited with options as well, because you never know when this patient's going to come in with distorted head and neck anatomy. You look down and the femoral site has a cellulitic or a big pannus that makes it difficult. This patient's going to need a subclavian line. Or how about the patient with that open book fracture that has a pelvic binder? And then you have a trauma attending, your colleague that says, don't take that C-collar off. This patient's going to need a subclavian line. And I worry about it because we're doing them less and less, and we're going to become less good at it. This survey from 2014 showed that emergency physicians are doing it less and less. You can see that 40% of these attendings over a year did zero subclavians. And this is a concern. If we continue down this path, the subclavian line is going to turn into the high acuity, low frequency procedure like a cricothyrotomy, and that shouldn't be the case. And I implore that to the attendings in the group, to be that teacher that the residents can go to and say, hey, I want to do subclavian today. I want to learn how to do it. Pass along the gift that hopefully is passed along to you. So how are we going to do that safely? And here are my 3 tips. And while I hope I still have your attention, in this world where seemingly everything is very easily canceled, I'd like to propose to everybody to cancel the term blind subclavian, throw it into cancel culture. While I understand I'm not visualizing the needle tip, I've yet to close my eyes or put a blindfold on while I perform or supervise the procedure. It is a landmark guided technique, and that's the way we should identify it as such. We use our in-depth knowledge of anatomy to perform it safely. And the anatomy really hasn't changed. 3 years after that initial French study, this Canadian journal actually spoke about the anatomy. Inserting a large needle into the chest of a subject appears frightening at first sight. It should not be undertaken without accurate knowledge of the topographical anatomy of the retroclavicular region. And thankfully, human anatomy hasn't really changed. There's a beautiful clavicle. One part, the first part of the clavicle that we need to focus on is that midclavicular line. If you hit the bone with the needle lateral to that midclavicular line on either side, you should be safe. And we're going to be aiming towards the suprasternal notch. Now, most of you should know this, but sometimes we're not going to get flashback. So on to my first tip. I'm going to move on to our real life patient. Another disclaimer, no residents were harmed in taking any of these pictures. But you'll see our midclavicular line there. Put the needle right just lateral to it. You see my index finger is pointed towards the suprasternal notch. That's my target. I'm going to go in that area. And as I aspirate, I'm going to pull back. What if I don't get a flashback? The way to adjust the needle is you want to go into the cephalad or cranial fashion on your second direction. Doesn't need to be a puncture, second direction. And why is that? This figure illustrates that the subclavian kind of courses above the clavicle to meet the internal jugular to get to the brachiocephalic trunk. So aim upward if the suprasternal notch isn't successful. Tip number 2, and it's probably most important in regards to safety. You really want to keep that needle and syringe as parallel to the ground as possible. And I understand undoubtedly that humeral head is going to get in the way, but you want to get as close to a 0-degree angle as possible. You'll use your thumb to push the needle underneath the clavicle so it walks underneath, and you aim towards the suprasternal notch. Whenever I see a resident do this, increase that angle, the procedure should probably be abandoned because that increased risk of pneumothorax and bleeding as well. So on to our third tip, and this is pretty easy one, pretty simple, but guess what? You shouldn't try more than 3 times. And this is a paper, or a large clinical series that evaluated 300 landmark central lines. And they compared characteristics to see which ones had the more complications. And it was interesting to see that BMI and even experience of operator had absolutely no significance. However, once you got more than 3 punctures, it was more dangerous and mechanical complications went up. So to recap, which is better long-term, Subclavian has less infection and less thrombosis. Is the subclavian safe? It sure is safe enough, non-inferior according to the 3-side study. Should it be taught, learned, and practiced? And that is a resounding yes. And then the tips to hit the target: aim towards that suprasternal notch, adjust cephalotocranial, make sure that syringe stays parallel, and then of course 3 strikes and you're out. So I thank you, and I turn it over to Dr. Pardeep Thandi.
All right. Thank you, Dr. Zygon. Thank you, Luke. My name is Pardeep Thandi. I'm coming from the Brooklyn Hospital Center. It's an honor and I'm humbled to be here today. So thank you for everyone for your time. So let's just get right into it. Let's pick up this debate here about the ultrasound guided IJ versus the blind subclavian. So say after your conference today, you have to work, but you come in and the first thing you see is a sick patient. You look at the IVC, it's collapsed. And you look at the monitor and the map is less than 65. So of course, the first thing you are is excited. Why? Because you are going to do a central line. And you have 3 places to go that we just talked about, right? We have our internal jugular vein, our subclavian vein, and our femoral vein. And you're wondering which one is the best? Where should I go for this patient? You're basically asking yourself, who is the GOAT or greatest of all time of central lines? And depending who you ask, you could have very different opinions on who is the best. So in honor of the number 23, I'm also going to give you guys 3 reasons why it's clearly the ultrasound guided internal jugular. Let's first talk about some theoretical considerations. There's this idea of compressibility. So what am I talking about? Well, we're obviously trying to hit the vein when we put in a central line, but unfortunately, sometimes there's things called arteries that are nearby that we hit. If you happen to hit the carotid artery when placing the internal jugular, that could be okay because this is a compressible site. Unless you do really strong exercises at the gym with your sternocleidomastoid, you'll still be able to put direct pressure onto your neck. Let's contrast that to the subclavian site. You can see here that if you happen to hit the subclavian artery, there's a big thing in the way that's going to prevent any compression. It's called the clavicle, and it's strong. So that no matter what you do, you can't compress it. This is particularly important on patients on anticoagulation or who are known coagulopathics, like our cirrhotics. And it's actually contraindicated to use a subclavian site in these patients because it's a non-compressible site. All right, now let's move on to the most obvious thing in the room is this idea of site. And what am I talking about? Ultrasound. Ultrasound brings so much to the table, and so we have to go into some of the things. So when you're trying to go down this road or you're trying to get this vein, you might find a block in the way. One, you could have abnormal anatomy, but even if your anatomy is the same, you might see one of these in there. A nice big hyperechoic structure right in your vein. More importantly, you could push down with your probe and you might not get any compressibility. So you might have a non-compressible vein. What does this mean? It means you can't place your central line in there. Doesn't matter how good you are. If there's a big DVT sitting in your vein, there's no way you're going to be able to get the line in. And without the ultrasound probe, there is no way to tell until after you're doing the procedure that there's a big DVT there. And that is particularly important in patients that have underlying malignancy or our sick patients are already more prone to having DVTs. Okay, but say the vein is patent and your patient's not at high risk for DVT. Why fly in the dark when you don't have to? Ultrasound allows you to see exactly what you're doing in real time. You can see your needle tip go directly into the vein that you want, and more importantly, you can avoid surrounding structures that you don't want to hit, like arteries. Even more so, a lot of these patients are hypovolemic, and they have respiratory variation in their veins with inspiration and expiration. So you might be trying to hit this target and not even know it without the ultrasound. The ultrasound allows you to time it that you can actually advance your catheter during expiration to increase your chance of getting the vein. Then once you get your needle in, of course, after you have to advance the guide wire. After putting in your guide wire, you then dilate. But sometimes even after passing your wire, you're still not sure if you're in the artery or the vein. And the color of the blood is not the best way to tell. You put on the probe, a longitudinal view, you can actually see the guide wire go into the vein before dilating, because the last thing that you want to do is dilate the artery. Lastly, of course, you put in your line, you feel good, you got your cell stuff off. The nurse wants to know, doc, can I use the line? Can I use the line? You want to get that lever head hanging right away. We usually confirm this with x-ray, but with the ultrasound already there, you can get a subxiphoid view of the heart, take your saline flush it, and in real time, immediately see that saline go into the RA and RV. This to me is good enough to confirm placement and avoid waiting the time and delay for x-ray to come by. But that's just how I see things, and that's just some theory. But we're here to talk about evidence. So what is the evidence behind this? So we just saw the 3-site study from France. So I'll bring up France again. And it was a great study, and it was done in multiple ICUs. And there's a great table, and there's a lot of great data there. But let me just give you the bottom line. The subclavian artery had higher incidence of pneumothorax. The internal jugular had a higher rate of infections. So what's worse, the pneumo or the infection? Well, I have a take on that. So there's been multiple studies, including this one in the New England Journal of Medicine, that showed an intervention can decrease catheter-related bloodstream infections in the ICU. So we call this CLABSI. And there's multiple studies that show that certain interventions can decrease CLABSI. And what is that intervention? It's simple: proper sterile technique and standardized checklists. And these studies, including this one, have shown up to a 66% decrease in CLABSI with just these two simple measures. So I would argue the risk with infection that we saw and we're seeing with the internal jugular, with just two simple measures that we should be doing anyways, and that most hospitals are doing anyways, this can be prevented. Compare this to this complication with the subclavian, the good old pneumo. And now it's really cool to do chest tubes, and we want to, but we shouldn't be excited about the ones that we cause ourselves. And this is not a good indication for it. All right, now let's go back to the ultrasound, my favorite thing. Is there any evidence supporting the use of ultrasound for central lines? Well, this would be the perfect study for this debate, of course. A blind subclavian versus an ultrasound-guided internal jugular. But that study doesn't exist. However, there's plenty of studies looking at site-specific areas and the use of landmark technique versus ultrasound technique. So in this case, the landmark internal jugular versus an ultrasound internal jugular. And this Cochrane review that came out in 2015 did a great job at summarizing this. Ultrasound guidance versus anatomic landmarks for internal jugular vein catheterization. They looked at 35 trials, 5,000 patients. So this is a big review. Let's see what they found. So for our ultrasound group, we had lower rates of arterial puncture, less hematoma formation, decreased number of attempts, and shorter amount of time with using the ultrasound versus blind internal jugular. All right, not bad. Now, what about success rates? Well, the blind group had an 87.6% success rate, the ultrasound group, 97.6. Complications in the blind or anatomic group, 14% versus the ultrasound group, 4%. So the evidence is clear that the ultrasound internal jugular has less pneumos, higher success rates, and lower complications. Now, what about the guidelines? Because there's great evidence, and evidence is important for patient care, but guidelines are really important because this is what experts in the field in our societies are reviewing all the evidence and coming up with standard of care recommendations that we should all be following. So let's look at a few of them. The American College of Surgeons recommends the use of ultrasound for all central lines. The Society of Critical Care Medicine has a level 1 recommendation that all central lines be placed with ultrasound. And the Agency for Healthcare Research and Quality has it as one of the top 11 evidence-based measures to decrease bad outcomes and increase patient safety by using ultrasound for central lines. Okay, fair enough. These are good guidelines. But what about ours, ACEP? Well, ACEP came out in 2016 with a clinical policy on a bunch of indications for ultrasound. And under vascular access, the primary indication is for central lines that it should be used to first look at patency and location of the vein when placing all central lines. So ACEP has stamped it as well that we should be using ultrasound for our central lines. So I agree. It is really cool to do a blind, to have your eyes closed and shoot a free throw, or to get a subclavian vein without seeing where you're going is super cool. But the last dance is over. And the theory, guidelines, and evidence all support a new era where we can actually see what we're doing, and that's with the ultrasound probe. And that is why ultrasound IJ is the GOAT. Thank you very much.
Thank you, Dr. Thandi. I knew this was going to be a good discussion. So we are going to move on to 10 minutes to talk about this topic. Before I let Dr. Saigan and Dr. Thandi kind of duke it out, I'm going to introduce my colleague, Dr. Jaiswal. He is the Deputy Medical Director and the Associate Chief of Service at Metropolitan Hospital. Dr. Jaiswal, welcome. I'd like to start off the panel by asking you the first question. So the burning question on the chat is, we're talking about blind subclavian, we're talking about ultrasound guided IJ, but what about an ultrasound guided subclavian line? What are your thoughts in general on this topic?
I would say ultrasound guided subclavian is probably one of the least commonly performed procedures, unless you have a very good reason. And if you're unable to do it, do an IJ, you'd probably do an ultrasound guided femoral, then subclavian. Subclavian, because of the clavicle itself, doesn't really lend itself very well for ultrasound guided placement. The supraclavicular, maybe you could do it as an approach, but I would definitely not have it as a first, second, or even third option in terms of using ultrasound. I would still go with IJ or femoral before I would even attempt subclavian through the ultrasound.
And to throw it to Dr. Thandi and Dr. Saigan, I mean, my thoughts, and I want to hear what you guys have to say as well, are don't our residents have to learn how to do, as Dr. Saigan said, a landmark guided line? At some point, the ultrasound machine won't be charged, it's going to break, it's not going to work, you have a trauma, there's too many people, there's not enough room. So maybe what Dr. Saigan was saying has some weight? What do you guys think?
I definitely agree. So as much as I love the ultrasound guided IJ, I think doing the blind subclavian for these reasons is really important. You could be an international elective, you could be at a community hospital where engineering has the ultrasound and is doing repair. You could be called down to a code or cardiac arrest in a SPART that's not your department in radiology on the floors, and they don't have ultrasound, and you might be asked to put in a line quickly. And without the ultrasound at your hands, you're not gonna be able, it won't be, the blind subclavian is a great option. So I think it's important for residents to train in this and learn it. That's kind of my take on that.
So
yeah,
then, go on, sorry.
Dr. Corrado also brought it up in the first talk, is that being dependent on technology could hurt us in certain situations. So teaching it and learning it and finding the situations where it could be practiced is super, super important. As it being, in regards to the ultrasound guided subclavian, there more and more evidence is coming out. The studies are pretty small, but since 2016, that they have identified approaches, and there actually is a great video on the New England Journal of Medicine, how to look the axillary approach using an ultrasound. Anecdotally, personally, I never performed this. Just looking at the video, you just seeing that pleural line so close to the vessel kind of turns me off on it. But again, that's the dinosaur in me. I think it's something that with more evidence and more practice, it could become more and more of a first line procedure.
Yeah, with the ultrasound guided subclavian, I guess my little take there is, so I like the idea. They're saying it's technically a little more challenging than the ultrasound guided IJ because of the clavicle there, and that's something we're not used to. That actually the same Cochrane group that I brought up there looking at ultrasound IJ, they actually did the same review with subclavian and femoral. And interestingly, I found that the subclavian actually didn't show any statistically significant benefit with overall decreasing complications and overall success rate. So I found that interesting. But then in the same year, there was a Canadian anesthesia group that posted a review over 10 studies looking at ultrasound versus blind subclavian, and they actually did find a decrease in overall complication rate. So I agree that I think right now the literature is coming out, but it's not like well established that using the ultrasound for subclavian has that benefit.
So should we even bother with an ultrasound guided subclavian? I mean, we've got lots of ultrasound guidelines. We have a great, easy, the landmark guided subclavian, it takes 3 seconds. It's really fast once you have the technique down. So what's the utility? Dr. Jaiswal, I know you trained at Lincoln, which is a big trauma center. So what are your thoughts on this?
So, as a dinosaur myself, I can definitely say that when I was training, all my attendings, either in the emergency room or in the ICU, most of them lean towards doing the landmark guided subclavian because that's what they were comfortable with. I have, in fact, our program director, Dr. Strugi, I know he said that he's actually never missed a landmark subclavian line, and he has missed it with the ultrasound or doing an IJ. But I think it's also on like your preference, your training, and your how comfortable you are with that. A lot of us, when we started, ultrasound guided was not that much a big part of our curriculum, and it's not something that instinctively we used to go for. I think now it's completely changed where residents today are so much more comfortable using ultrasound for different modalities. So I think that's why it tends to get preference now. So even in our program, as you can probably attest, the first preference is going to be an ultrasound guided central line. And if you miss, you might even try the femoral ultrasound guided, and maybe in a third or fourth situation, maybe try the landmark subclavian. But I definitely, agree with Lucas in the sense that it's definitely a skill that needs to be learned, that needs to be taught, because, it's always a tool in your arsenal, and you never know when you're going to need it. So you want to make sure that when you do use it, that it actually is useful, that it actually serve the purpose of what you're trying to do. So I think we should definitely make it a point, either through simulation or in different practices, of teaching it to the residents, because that is definitely a skill that eventually will be lost, because ultrasound is only going to be more pervasive in our practice, not less. So it's not actually going to go away. So I think, as you said, depending on technology is always a bad thing. If you can't function because you don't have an ultrasound, that would not be acceptable anywhere. So definitely learn it, use it as maybe a second or third option. That's kind of like how I approach it.
So how do we get our residents to learn it? It's kind of the same conversation that we had with the VL versus DL lecture. How do we get our residents to learn it if we're all hesitant and we're all pushing ultrasound? And I know right now I have some residents who've graduated and work locums, and they don't have ultrasound machines when you're working at these very remote locations. Actually, right. I was very surprised to hear that. So why are we all always pushing ultrasound? It's the same thing. We do need to get our residents to do subclavians. We talked about basically there's risk of infection versus risk of pneumothorax. So I know you ended with a very strong comment on that, Dr. Thandi. Dr. Saigan, what's your take on his take-home message from that?
So, I think it's important identifying the situations where it could be placed in a safe manner. That's how we're going to teach it. That's how we're going to get our residents to do it. Even though my last paper showed that body habitus had nothing to do with it, you're going to look at the landmarks, see what's a good landmark. You're going to know the contraindications, which that Thandi also brought up, the supertherapeutic INRs, the thrombocytopenic patients. You're probably going to stay away from those. But you should try and look for those situations where it's possible. It's like the airway, sometimes it can be hard to predict, but at the same time, with experience, you can identify those cases so that we can pass this gift along in the right scenarios.
Dr. Saigan, do you know in the literature, I'm not sure if it came up in the papers, how many of those pneumothoraces were actually clinically significant and needed a chest tube? Are there studies that go over that? Because that obviously makes a difference.
So the 3 sites paper that we spoke about, actually the only mechanical complications the only pneumothoraces that they brought up are grade 3 pneumothoraces that needed some intervention. And most of the studies really do identify that it's not just like this occult pneumo that gets better after 6 hours of oxygen. The literature is pretty good in identifying the clinically significant pneumothorax.
And just to echo with Dr. Zeigan saying, I completely agree. I think that there's some, we have to actively look when we could use the subclavian, vein blind. And a couple indications. One, in hypovolemic patients, because I showed the picture of the respiratory collapse, actually the subclavian is bigger. So if you have a very hypovolemic patient, that might be like an indication that maybe I should be doing the subclavian because it's going to be have less respiratory variation. And then you could argue too, if somebody already is going to get a chest tube on its side, or already maybe going to do a finger thoracostomy, if that's something that's part of your practice in cardiac arrest, then your risk of pneumothorax is going to be less because you're going to be evacuating that space anyway. So I think I agree completely with Dr. Zeigan that we need to learn it and that we need to just actively look for the opportunities where we can train our residents for this.
And so I wanted to direct this question. So Dr. Jaiswal, you're the Deputy Medical Director and the Associate Chief of Service. So your goals are more departmental based, patient safety focused. We're a little bit more on the educator side and always pushing for the residents to get the best education. So some different ways that we can confirm. So let's move away from blind subclavian versus ultrasound guided subclavian. And I'm going to still talk about ultrasound with the subclavian. So technically, I can do a blind subclavian line and then confirm it with the ultrasound. Let's say it's a trauma. We got a C-collar. It's abdominal trauma, so I'm not going to place a femoral, and there's no room for my ultrasound. There's too many people. I place the blind subclavian, but I don't want to wait for the confirmatory chest X-ray. Can we just use the ultrasound to confirm it? It's not common practice. It's not standard of care. So from more of a departmental perspective, how would that look when you're looking retroactively at charts?
So, the thing is, it's all good if things go well and there's no problem and you're able to confirm with the ultrasound and everything is fine, and actually patient benefits from that early intervention and being able to use the line. The problem comes is when something goes wrong, right? If there's a complication that develops, and no matter who reviews that whole case, and this is me putting more my admin and quality hat on, is they're going to see if there was any deviation from what is standard of care, okay? And that whether it contributed actually to the whole situation or not, whether your ultrasound use of for subclavian and confirmation, whether that actually was even contributing to the complication of that patient, that is going to be something that you will constantly have to explain. That why, when conditions permitted, did you deviate from standard of care? Because these guidelines, that are sent out by all these different organizations, they do have some sort of meaning, and they do need to be observed and followed. They're not rules, but they're guidelines. But even if I were to move to even a medical legal risk management point of view, again, anywhere where there is standard of deviation from of standard of care, that is going to be a problem. So it becomes harder to defend a complication in that situation.
Obviously, which is why a lot of us go on. Dr. Zeigan.
That being said, and I agree with you, when things go wrong, there is enough evidence that you could say that I'm supported by there's safety in these lines. Again, my first line is probably going to be the ultrasound guided IJ, and I don't know if the defense enough is if I cause a pneumo by practicing one, hey, I got to keep my skills up. It might not. The risk management department may not like that, but being in education and academia, I think it is important. Yeah, but there is evidence to make it an argument when things go wrong.
I mean, I agree. You can always make a case, but if someone asks you, Dr. Adamakos, did you follow standard of care in managing this patient who now has a severe complication? And even if it had nothing to do with you, it's actually, you're going to end up defending that whole case. So from a risk and medical legal point of view, especially that becomes important when you're practicing in remote locations where you don't have much backup, right? Because the chances of complications are potentially higher, or you have less backup and less resources. So in those cases, it's a very fine balance, because you also want to make sure that, you know, your residents are practicing safe medicine, safe for the patient and safe for their own careers as well. So, you know, as much as I support academia, and I definitely think that, you know, subclavian is something that we need to learn, and we need to use whenever we can, and encourage our attendings to do that. You have to keep in mind the bigger picture as well, because that can sometimes kind of get lost.
And I think, you know, again, the trauma patient, abdominal trauma, you're suspecting also an unstable C-spine fracture. I think it's easy to defend going to do a subclavian. Obviously, it becomes the other patients that's a little harder. Right. Now, for all the panelists on here, some questions came up in the chat. Let's say you have a crash patient, you're doing CPR on them. Maybe trauma, maybe not. What central line do you find you have the highest success, or your residents? A lot of times these are the interns that we have them do the lines for this. What central line do we think is the fastest to get during CPR? Forget IO, there's an IO, it was placed, it doesn't work. Let's just take IO out of the picture.
So I personally would probably try the subclavian on the right side, and maybe have some other people try the femoral. That probably would be like the, you know, try and attempt both sides at the same time. So that probably would be my approach.
I think for the most part, you know, the trainees are using ultrasound guided femorals now in cardiac arrests. I do think, and it is brought up by some of maybe one of my mentors, that it is an excellent area of to practice the subclavians because of the lower risk. But again, universally, I think, because of the experience, because people like that ultrasound machine and they use it more frequently, the ultrasound guided femoral lines are what they use more commonly.
Yeah, we're using blind femorals. However, I agree. I think this is a great opportunity to be using the subclavian, and I'm glad that other places are using it there. And then I would say also this might be an opportunity like for a supraclavicular approach to subclavian, because now if someone's doing CPR here and you can't access the clavicle, now you can take the supraclavicular approach. I guess one of the studies was saying the landmark approach is equally as safe, and that with ultrasound supraclavicular approach, they actually had like shorter time of procedure and higher first attempt success rate. So that might be, I think, a good indication to even start to try the supraclavicular approach during cardiac arrest.
One last question for you guys, and then we're going to move on. There's been some chatter about using manometry as a standard approach to secondary confirmation of central lines. Lots of ICUs and anesthesia colleagues are using it. I know I've never used or heard of this approach. Again, I'm ED, I'm not ICU. Do any of you have a comment on this?
So in my research of doing this, I did see some papers that spoke about this, and it was mostly in the anesthesia ICU journals. You know, you need certain tools, you need an A-line sensor to do this. I think it adds a little bit more time. I think using an ultrasound in this to confirm the guide wire placement before you dilate, like Dr. Thandi brought up in his lectures, is good enough. It should be the standard of care. The papers that I saw didn't really go into that. They went into VBG, ABG sampling, but that, I mean, that's a great future study that I'm sure is going to come down the pike.
Awesome. All right, guys, thank you. And it was really great hearing from all of you.